amazing pleasure to introduce you to Dr. Eric Widera, guys. He is an amazing leader in both geriatrics and palliative care, and we're super happy to have you here. We are about the same generation and have been growing up together in palliative care and geriatrics. This is the palliative care team, so I think we're going to go ahead and introduce ourselves to you so you know who is here. But Eric is an associate professor at the University of California in San Francisco. He did his internal medicine training at Mount Sinai and his geriatrics training at San Francisco. And he is well known in our world for the recent article in JAMA that he published about prognostication. He's done a million things, which I'll be telling you a little bit about tomorrow when he does our medicine grand round. Scary. So anyway, and he's going to be meeting with some of you at different times today, tomorrow, and Thursday. He'll be also teaching us during Thursday afternoon sessions, especially for the fellows. So.
What is Benjamin Wilson, a healthcare chaplain?
What's your first name?
Benjamin?
Benjamin.
I'm Mary Brown. I'm a clinical bachelor's treatment supervisor.
I'm Jennifer Healy. I'm one of the attendings over at University Hospital.
So we start off with just looking around. There's some great blogs online. So healthcare blog, health affairs blog, PalliMed. Have you guys seen this?
Mm-hmm.
Great blog for just focus on palliative medicine, although recently Christian hasn't really been posting that much. So 3 years ago we decided to create our own blog. This is what we initially started off as, called Geri-Pal. Have you ever been on it, ever heard of it? No? So, one, good. So we started this off as a budget of zero, mainly just as a hobby. Really easy to do. You can just go online to Blogger and create your own blog and set it up. And 3 years ago, we just started posting online. Thoughts, things that we thought were really interesting, things that we were passionate about in geriatrics and palliative care. And we slowly grew. So initially, we hung around like 5,000 page views a month. We had an initial pretty dramatic increase, and then kind of leveled off as far as growth over the first pretty much year and a half. But the nice thing is that we started developing a following, people who actually liked going to our sites. And this was healthcare professionals. This was the audience that we were mainly targeting. So medicine, nursing, social work tended to be the big three. We had some chaplaincy on our site, and few students. This was the first year after actually creating it. And the nice thing also is that they weren't the usual suspects. So these weren't the people that we usually saw when we're sending out articles to JAMA or articles to the New England Journal. These are people who are working in the community setting mostly, so community hospitals, home hospice agencies, people who may not have access to big libraries that we're used to and the way we're used to disseminating medical information. Although a good portion were in academic hospitals, academic clinics, home care, community clinics. And they tend to like us. At least most did. 1% did not think we were valuable. But many of them did. So some regard us as very valuable, extremely valuable, or somewhat valuable. And then we decided, okay, it's been a while, maybe we should start focusing a little bit more on developing the site. So we put a little bit of money, mainly hired somebody to add some pretty graphics to the site, and redesigned it and started publishing more and more, started becoming a little bit more of a content expert. And we've grown. So we started off about 5,000 again, and over time we've grown to about 50,000 page views a month. So it's expanded, it's grown. Our subscriber base actually has grown too. So subscribers by email and RSS readers. So currently we're at about 1,600 people who get our emails every time we post something. And we're involved in social media, so Facebook, we're involved in blogs. we tweet. So I tweet pretty much multiple times a day, maybe 3-4 times a day. Our blog does it, and it does it automatically about once a day. And the really cool thing is that as we've grown, we've started having other people follow us too. And I think what was most surprising, we started having journalists follow us. So this is one example of a journalist who followed us. So this is a post by Dan Matlock at the University of Colorado, another geriatrics and palliative care doctor. And he wrote about a time where somebody was accused him of murder. So this is the beginning of this post. You would have been hung in World War II for doing what you are doing now. I was told by a prominent member of the surgical service at my hospital when I suggested we stop intravenous hydration. A very kind of powerful, moving post that he wrote about. And it was picked up by the New York Times, the New Old Age blog by Paula Spann, who wrote about it, who interviewed Dan Matlock about this post. And it got a lot of attention, and he got a lot of attention, so he also got interviewed by Colorado Public Radio, so you can actually go to their website and listen to Dan Matlock talk about this particular experience. Nice one,
Perfect timing.
Again, it shows that your voice can be heard out there among the cacophony of sounds that's on the internet. Your voice is actually important, and if you bring it out there, people will listen because people will look at you as a content expert. The other thing I wanted to talk about too was using social media to advance your cause. What's important to you? So just going around the room real quick, I'm going to put you on the spot. Are there topics that are really important to you? Geriatrics, palliative care, and medicine, is there anything that you really are passionate about?
I like music.
Music. Okay. Is there any particular, how about in geriatrics, palliative medicine, in medicine in general, is there anything that you're passionate about?
I don't know. There's nothing on top of my head, but
I'm passionate about autonomy.
Autonomy.
Patients feeling that they have autonomy to continue with treatment, refuse treatment, that they feel they have all the information they need to make a decision.
Good. Hold that thought too, because we're going to be getting to what to do with it. What else?
I can say that I'm passionate about, we have a lot of patients that are young at our university hospital, and somehow when a patient is young, they get different care. It's even in palliative medicine than patients that are older.
Pediatric young or young
no,
adults?
like in young in 30s, 20s, 30s. And it's always like everybody has the hardest time, giving them good palliative medicine but they're so young, how could we give up and all these things, but the patient is suffering and dying, and we take care of them differently. So I'm kind of passionate about trying to get people to, of course we want to think about somebody young, we want to do all that we can, but when we're at a point that we've made a decision to take care of them, and at the end of their life, that we actually take care of them instead of letting that they're so young, change exactly what we do. So.
Sandra, what are you passionate about?
I'm passionate about teaching end-of-life communication,
Teaching end-of-life communication.
advocacy, and mediation.
So there's a lot of things that we're all passionate about, whether it be teaching end-of-life communication, whether it be about the younger adults who end up in the hospital who receive very aggressive care, sometimes despite their own wishes and preferences. Whether it be about something outside of medicine, like music. How could we harness kind of a new media that's out there that's not so new anymore to actually promote those things. So I'm going to give you one example. And this is what we did, and this is what I'll be talking about tomorrow too, is helping clinicians estimate prognosis in older adults. Is that we actually thought it was actually really important, not just to think about prognosis for cancer, for heart failure, for COPD in older adults, which are important and important that we think about. But when we think about older adults, do they tend just to have, let's say just our veterans that we're dealing with, they tend just to have COPD, dementia, heart failure? What do they have? Everything. Yeah, they're taking like 30 medications, and they're on, their problem list is, 10, sometimes 20 problems long. It keeps on going and going and going. So how are you supposed to think of prognosis for a single disease like COPD when they don't just have COPD? They don't just have prostate cancer. They have multiple diseases together. How are we supposed to prognosticate in those issues? So that's what we were passionate about. We started looking into and developing a systematic review on prognostic indices in older adults for people who do not have one specific dominant terminal illness. Rather, they are aging, they're having more functional decline, they're having more comorbidities, and how do we actually help those individuals make decisions that are congruent with their preferences and are also congruent with their prognosis. So what we decided to do is that we decided to create, again, a systematic review, but also at the same time we started thinking about how could we make it a little bit easier for people to have access to this information. So putting this information online, giving providers, healthcare providers, access to it so they can quickly go to these indices and input information and come up with a prognostic score to help with their clinical judgment. But we also wanted to make sure that people used it and people understood it. And this is where the power of what we've developed with our blog, with our social media, is that we were able to go to our new friends. So this is Paula Spann from the New York Times, and asked her to write about this for her audience, and ask her audience, and this was a very big discussion we've had, is should we just limit this to healthcare providers, or should we open it up to the public in general? So if you were going to develop a website that had multiple different prognostic indices that gave people an estimate of how long they may have to live, should it be just limited to healthcare providers, or should we open it up to the general public?
Open it up to the general public.
Why?
So, when we as doctors or the caregivers tell them, about their overall prognosis, they could also see it for themselves, when
Yeah.
they put in their medical problems, and, maybe they can relate to us, better, and, not think that we are just trying to give them a number because, we are the doctors.
We give them information, yeah.
And another reason is that now more and more people, when they find out there's something going on with them, they'll go to the web and start looking up information.
And we'll go over some of that data too. But more and more people, and older adults and caregivers, are going to the web to look up information, either before or after they see you. Devil's advocate here. Anybody want to?
Yeah, well, there is.
Devil's advocate, nice. What's your name again?
Aziz.
Aziz.
There is a concern that if they look at these prognostic factors, they emphasize more on like that 1% chance of survival. And when we as physicians think that's not too much, but they might really clinch on to that.
Yeah.
I can still do well.
Yeah. And that's true both with the verbal communication, so, and we'll talk more about this tomorrow and on Thursday, is that even when I tell somebody you have a 1 in 10 chance of surviving, they're gonna of jump on that. Versus if I say, actually, and framing is really important, and Sandra can talk about this more, is that if I say 9 in 10 chance of dying, statistically, exact same thing, they're going to view it very, very differently. So it does depend on how we frame these discussions. So numeracy skills of people going on the internet looking at these sites are going to be varied, but in general, numeracy skills of most adults in America are very low. They're not going to be able to really understand complicated statistics or much statistics in general. So what are they actually going to get out of the site? And will we just confuse them even more? Or worse, what if they see that they have a 90% chance of dying in the next year? What if they decide to go through all their money and in truth they're alive in 5 years, 10 years? How much are they going to understand of uncertainty? We don't have a crystal ball. Any other? Any other reasons to do it?
I just feel sometimes, in terms of communication, when we give them that estimate, it's finally talking about, this huge elephant in the room, and then they relax, and then they start talking about, funeral arrangements, that how my house is gonna go to this person, and so prognostication, even if it's wrong, is a tool to have them talk what they need to.
And added on top of that is that most physicians will not discuss prognosis with patients. They'll talk about prognosis if patients bring it up. And patients generally will not bring it up unless their provider brings it up first. Although most, even most older adults from multiple different backgrounds wanted to discuss prognosis, even if their provider didn't talk about it. So one of the things we were thinking about is if this does get into the general public, maybe we'll start getting people to talk about the importance of prognostication. Because much of what we currently do in medicine is about diagnosis and treatment. And prognosis has, the kind of third big pillar of medicine, has pretty much dropped by the wayside. So if you look at textbooks from 40 years ago, you'll see a lot more about the prognosis than you see textbooks today, where there's actually very, very little when you're actually looking at specific chapters. Or if you go to up-to-date, how many of you guys do up-to-date? Yeah. Maybe, like, if you read about, like, COPD or CHF, maybe there's a little section on prognosis. But there's not a whole lot, but there's probably its own chapter in up-to-date on AICDs or specific interventions. So just something to consider.
I don't know if this is almost like a devil's advocate position or not, but it seems like something related to this is how pharmaceutical companies have advertised medications so that then general public reads the advertisements or sees them on television and wants a particular medication that has a lot of technical information that is not well understood by a non-professional person. So then there's a risk in, like, you want to increase knowledge and information on the one hand, and on the other hand, if it's not understood or misunderstood, then creates more conflict.
Yeah. And risk for serious harm.
Mm-hmm.
They may not do something that they're supposed to do, or that they should do, because they've misinterpreted the data. And pharmaceutical companies love doing that. Like, you hide it in the small print. So we actually asked, again, our colleague at the New York Times is ask her readers whether or not this should be online. What did the general public think? Because we had a lot of these discussions with people at UCSF, providers, social workers, nurses, about what their thoughts are, but we weren't really asking older adults or caregivers, should this information be online? So she actually wrote a post about it. And the other nice thing is this was also building up some momentum for our hopeful eventual launch of a website. And the readers pretty much spoke out that absolutely want this information.
I just thought of something when you said that a person would go to access the internet and go and do some research. I just realized, in my background, I'm sure a lot of us as being educated, we don't usually go to the internet to find, Wikipedia kind of strong sources that we can quote and we can rely on. And I'm hesitant to go to blogs because they're not like in a textbook. I don't go to the library and pull out the shelf. And I just realized that when you said that, oh, let's look at this blog. I think it's kind of the hesitancy, but it sounds like what you're trying to create is something with some teeth and something that's, that does have that,
Reputation.
Yeah.
So a lot of it, and this is the other important part, is because we were publishing something that wasn't directly supported by UCSF, but we were UCSF physicians, we were geriatric doctors, we were palliative care doctors. We are using that to build trust, to build reputation. And we took that kind of very seriously, is that anything that we do right on the internet comes with that backing and the trust that we're supposed to be developing. So we're very cautious about what we post on the internet to make sure that we don't break that trust, break that level of authority that we have created. So if we were going to post something like this online, is that we realize that we're not Joe Smith, is that we are part of an academic institution and we have a level of responsibility. But that also gives us a lot of street cred, is that people do come to us and they ask us questions, or they'll say, yeah, I'll write this for you for the New York Times. Like that just wouldn't happen if you weren't part of an academic institution like you guys are here.
Let's see. The original question was, should it be private or public?
Yeah.
And I think with the private industry, there's more, like if I go on to EBSCOhost, and there's this, a specific journal, and everybody comes together, and I think that's what it sounds like when it's been created.
Well, I'll actually show you what actually happened. Is again, all the public basically said, we want this information online. We should have access to it. We funded this research. Why don't we have access to it? And many of them said that their physicians aren't going to talk to them about it. That they want the information so they can make better informed decisions. And this is a very different probably population than population of 30, 40 years ago that expected more of a paternalistic approach to medical care. And this is more about autonomy. We want this information. We want to make decisions that are consistent with our values and goals. And it led to, this post came out. We got some more press. This is MSNBC talking about life predictors of lifespan. And the fascinating thing about when you talk to media is most of them have actually, they may just read the taglines, but by the time you're actually on air with them, they have no idea what you're actually trying to do. So they thought we developed a calculator that would give you the exact time that you would die. And they loved that story. And then when I went on online at MSNBC, they were kind of like let down. But again, building a little bit of momentum for the research that we were actually doing, which is a very different model than the old traditional way of disseminating your academic products, which is through journals. How many of you have read the last New England Journal article? Last JAMA, Lancet, BMJ? How many of you actually, and I'll be honest with you, have read a physical journal in the last month? Okay.
You're talking about on the
Like,
axis.
no, like, open it up,
Like, you put it on
read
the
through
computer.
each article. No. It just I mean, I have stacks at home of, I will eventually get to these because I'm not going to throw them away until I read them, and they just keep on getting higher and higher and higher and higher. And in truth, even when you publish in really reputable journals, the amount of people who actually read your article is strikingly low. The old model of academic dissemination is a very poor way to disseminate information. So we actually published online and on the JAMA website a systematic review of prognostic indices on January 11th, 2012. So big journal, JAMA, big readership. Honestly, the amount of people who actually read this article was probably strikingly low, even though that it was in a very notable journal. But this is the traditional route. You publish in a nice journal, you get that on your CV, you go on to something else, and nothing really changes in the world. We also decided at the same time to launch ePrognosis, which is our website that we're creating, we're continually modifying to actually help healthcare professionals prognosticate in older adults. And we can talk a little bit more how to use this at another time. But at the same time, as this launched, we launched this, and we also were working with colleagues in the news media to actually publish information about our site and our systematic review. So again, this was on the front page of on January 11th on the New York Times health page, and electronically online it was actually on a front page cover story too, on interactive tools to assess the likelihood of death. People loved the story because it said the word death in it, and picking death. And if you ever want to get some attention, you just throw in the word death into an article and people will eat it up online. And we opened it up to the public too. And this created some controversy. We had 6 New York Times stories on it, USA Today stories, Daily Beast, AARP, MSNBC, Le Monde. Like, it was actually being picked up in newspapers in France. And within the first week, we had 500,000 page views of our website. So a lot of people coming to it, not from JAMA, but because we disseminated this research outside of that traditional route. And within the first 2 months, nearly 750,000 hits to our website. So this is just one example of how you can harness what we did. Is if we just use JAMA, the traditional route, it may have not gotten a lot of people to actually hear about it. I may have never been asked to give grand rounds about it tomorrow. But if you can harness these techniques, you can actually push your message forward, advocate for your cause, whatever that is. And this is how we advocated our cause, not just within the healthcare professionals, but to get people to start having a discussion about the importance of prognosis. So I'm just going to give a couple other benefits, and then we're going to do a little exercise too. So these are some other benefits that I've actually noticed about going online. You get immediate post-publication peer review. So instead of pre-publication peer review, which happens like before you actually publish, you send it to JAMA, they give you, critique, feedback, they may reject it, but the whole process takes half a year to a year. There is no immediacy about it. What's the shortest you ever had on a turnaround?
A month and a half.
A month and a half. And from inception to the end, how long does that take?
The shortest, about 3 months. The longest, 7, 9 months.
Yeah. For our systematic review, it was almost a year. From inception, time when we thought about it, till the time they actually got published in JAMA. So a very long period of time. This is immediate. You post something, it's out there for everybody to see. You develop a network of colleagues, so we've actually developed colleagues throughout the U.S., and it's really easy to do because there's not a whole lot of health professionals using blogs, using Twitter, but there are some who are very high up there in the world. So how many again are palliative medicine here? Diane Meyer, have you heard of her?
Mhm.
She's online. It's amazing, like to have the ear of Diane Meyer and to communicate with her online through Twitter is actually really easy. For me as a junior faculty member, it was a great way to actually get to know some of these people who are using these social media sites and to have a discussion with them online. You get a perception of being a content expert, so if you write something, like if we write something on our blog, we'll get a call from a reporter or someone, but I may not actually have thought about the subject too much, but they think I'm a content expert. But it's, again, a great way of pushing yourself a little bit and to get a little bit of a more national reputation. Increased involvement in national societies. How many of you are members of AGS? AHPM? So we've given multiple talks at AGS and AHPM and SGIM on the importance of social media, how to get involved in social media, and why we should get involved in social media. And the other nice thing is you go beyond traditional methods of dissemination. We talked a little bit about that, but I just want to highlight one thing, is that it's not just this healthcare professionals who are online, it's older adults and it's caregivers. So over 50% of older adults greater than age 65 are online. So they're using the internet. You know, as you get older and older, they're mainly using it for email, but up to a third of older adults are using social media, Facebook often, or some other thing like Facebook. Caregivers, so 30% of adults are a caregiver, so they help with personal needs or household chores, finances, arranging services, visiting daily sometimes. Of these caregivers, almost 80% have access to the internet. Not all, but most. And if you do have access to the internet, most of these look for online health information. So going to your original comment. So what do they look for? What do caregivers look for? They look for specific information online about specific diseases or medical problems, medical treatments or procedures, doctors or health professionals they want information about. They want information about memory loss, dementia, or Alzheimer's. They want to know how to manage chronic pain and how to manage end-of-life decisions. And all of these are statistically significant differences from non-caregivers. So caregivers want more of this information, and they're looking online. And they're also looking for information on their health through reading blogs. Some of them may be trustworthy sites. Some of them may not be trustworthy sites. So there's a concern there. They're also looking at videos. So we're going to go into our exercise now. So I want you to think about something that you're passionate about. Again, it could be music, it could be about something about geriatrics or palliative care. Try to focus a little bit on geriatrics or palliative care. And I want you to practice writing a tweet. So how many of you are on Twitter? 1, 2, not yet. Not yet. So it's really easy to do. How many of you have smartphones? You can sign up in like 30 seconds. So if you actually go online, so this is the Twitter main page, you just you type in a full name, an email, and a password, and then you sign up for Twitter, and then you're basically signed up. You get to this page. You can pick a name. Like I typed in as my username Eric Widera, and that name's available. You may have to look around for different names. The key for any username is keep it short, because you're only allowed 140 characters. So if you have a long name, it takes up most of your space. So Sandra, what's yours?
DRSESR.
And then you basically join, and then you can follow interesting people online. Interesting people in both geriatrics and hospital medicine. So these are some of the people who are online. Mark Lax, Paul Stanton from the New York Times, William Dale. Do we know this person, right? Diane Meyer. And what I actually use it for is, instead of reading every single journal on the face of the earth, I follow people who tend to actually bring up interesting articles that I may have not seen because it's not in one of the 3 journals I tend to look at. And then, so this is an example of the last American Geriatric Society meeting. And then you can follow tweets. So Ted Johnson talked about advice of the geriatric 4-degree course. Don't prescribe drugs whose names you cannot pronounce. So little pieces of information. I'm part of the Palliative Care SIG at AGS, so I talked about people going over to the Palliative Care SIG, so start getting people interested in it. And it could be stuff like, for AGS, best latte in your life, where to go. Which was actually really helpful for me because I actually went there and it was a really good latte in Seattle. So it could be different information. And it was all around this hashtag AGS12, which is basically a search function. So you can click on it and it pulls up every tweet that has AGS12 on it, American Geriatric Society 2012 name. And then you can do little mentions like at Doc Tatum is Paul Tatum from the University of Missouri.
It's coming in 3 weeks.
It's coming in 3 weeks, so you can all be on Twitter when Paul gets there. American Geriatric Society has a nice little handout on how to actually tweet, how to get online and write a tweet. So you can actually just go to American Geriatrics, Google it, and go to Twitter. And these are just some Twitter basics before you have you write. So the golden rule is 140 characters or less. A hashtag is basically just a search function. So like hashtag geriatrics is a way to see what people are writing about in geriatrics. Hashtag HPM, do you guys know what that is? Hospice and palliative medicine. You can put the @ symbol and a name, so this is mine, and this mentions somebody, so I'll know if somebody is trying to actually tell me about something. And retweets are just a way of, if somebody says something interesting online, to spread it to your followers. So again, for instance here, hashtag search function, this is just a mention. So I know that I'm just basically saying his name online.
So if I wanted to retweet your post, I will have RT.
Yeah, you can do RT, @ewadera, and then this. Or there's generally, when you actually go on Twitter, there's a reply and there's a retweet button. You just hit the retweet button and then you go. So I want you to practice. Split up in pairs of 2. I want you to write something about what you care about. The key though is has to be 140 characters or less. So if you don't have something to type into, about 25 to 30 words. If it's on geriatrics, include the hashtag geriatrics. And if it's about hospice medicine, include HBM. If it's about music, include the hashtag music. Or it doesn't even have to.
And if they wanted to use the app, it's Twitter.
Yeah. So you can actually just go online with your smartphone right now and download the app for Twitter, and then you can actually just sign up too. Okay. So everybody take. We'll do like 4 minutes. Write a tweet. 140 characters.
I don't have it. Are you on? You're on? Are you on Twitter?
Interesting
Two,
enough to be on Twitter.
two, and 2.
Okay. Yeah.
See that wireless now.
Is his name Gutman?
We have, don't tell you,
Is that his name? Gutman? Jerome Gutman?
So,
I just thought, yeah, Jerome Gutman?
Groupman with an R.
Groupman.
The oncologist.
We will. Okay.
Go ahead.
Okay, we have two.
Two.
How we can live with our grandparents in a Western society instead of visiting them in a nursing home.
Nice.
And then mine is, have you hugged a caregiver today?
Have you hugged? I like that. Have you hugged a caregiver today? You know, the nice thing about that, it's actually kind of catchy too. Short, simple, sweet, and then you can also, I think the interesting part is you can also add a link to it on Twitter. So if you're thinking about getting people to, let's say, your website or an article about caregivers, you can get people to start going.
Okay, that's a good idea.
Yeah.
So we have two. They're very short and to the point. So we did hash mark HPM, and there's quality of life and end of life care. Hash mark geriatrics. So palliative care is often associated with as is geriatric. It really is still living.
Yeah.
So that's not a hash mark.
That's
The other
good.
one is hash mark HPM, learning about social media at New Era. Hash mark geriatric.
Nice. You guys have one?
Yeah, we have one, but I think it's a wrong one. I would put what we are interested in, and it says geriatric transition of care from the hospital to home or nursing homes, helping patients and families to understand complexity of their medical conditions.
That's good. I think that's more than 40 characters.
Yeah.
You're good.
Okay.
Sandra, you have one?
Yeah, you would teach an hour HPM team about disseminating our field via social media. I actually tweet.
And you tweeted it. I'll retweet it.
All right, we have friends, family, and colleagues. Google Prognosis app, courtesy of @eWidera, #HPM.
So the interesting thing too is that do not underestimate the power of goodwill too. So if you like send out that tweet, and you can send out a tweet, and this is how often we build relationships with like reporters, is that we start talking about what they're doing, and then they start talking about what we're doing. So if you do that, I retweeted to my followers, which was about like 2,000. Diane Meyer may retweet to her followers, which is about 3,000. So now you have like 5,000 people who are reading this one tweet. Not again, not all of them will be reading the tweet, but at least it starts expanding beyond the traditional wall.
Do you have to retweet our post to be able to be reached to your followers, or if we put your name, if your followers proceed?
So my followers will only see the stuff that I write or I retweet.
Okay.
And that's how it things can kind of spread virally. So if one person retweets and another person retweets, then you can get into, you know, hundreds of thousands or even millions of people getting that tweet.
So ours is #SPM, suffering or survival of the patient, and treating the patient or the family.
We just recommended an article. We put #Groupman NYER, New Yorker, about ABT delivering bad news. And I didn't put the date because I think it's 2002, but I mean, it's mine. But.
And again, the nice thing is that you can actually copy that URL on the web for the New Yorker article and paste it in, and it will actually shorten it for you so it doesn't take up all your space. And then people can go directly to it, which is the great thing about it.
Well, we did a hashtag of spirituality, and I don't know how exactly to put an author down if I wouldn't know a book. Miriam Greenspan, and she says redemption of fear, grief, and despair requires we go through, not around. And this is like Good Friday, Easter Sunday message in Christianity.
And there is actually a chaplain community online.
So would you do a #chaplain as well, or?
I don't know. I don't know if it's chaplaincy or what the specific hashtag is, but I know I've seen them.
Great new world.
We were being fairly simple since we're,
It's called
we were just saying,
Sorry, healthcare chaplains.
Oh, that's in New York City,
Mhm.
the healthcare chaplain.
And their log is at meaning comfort. That's what they
Okay.
so we were just saying, Eric Videra, teaching hospice and palliative medicine fellows at UTSCA. That was our sorry.
So-
We're not that creative.
Lots of different things. You can
But we
talk
wanna
about
bring
what you're
people-
doing right now. Again, people always make fun of Twitter, like, I don't want to talk about that, what I'm eating for breakfast. But the truth, nobody really does. You talk about things that are meaningful to you. And then once you start talking about things that are meaningful to you, people understand who this person is online. What's your online persona? This is what's meaningful to this person. Like for me, it's about, everything I tweet about is about geriatrics and palliative care. I don't tweet about what I have for breakfast. Sometimes, if there's a really interesting article outside of geriatric healthcare, I'll tweet about it, but and it develops that online persona. So thank you all for sharing. The other thing that I'll just briefly talk about is you can also consider blogging. This has been great for me as a junior faculty member. Now, I just got to associate, and even when I moved to assistant to associate professor at UCSF, I talked about my online presence, and it actually did help me get promoted from assistant to associate. And a lot of that was just because it was easy for me to get a lot of people from across the nation to write about me as far as letters of recommendations, because they knew me. They didn't know me from a national meeting, but they knew me online too. And it's really easy to create an online presence. You can actually go to any of these sites and start up your own blog. It could be about music. It could be about anything. Think about doing it for geriatrics or hospice and palliative medicine, because the field needs people talking online. So when somebody Googles palliative medicine, instead of going to some site that may not know what they're talking about, that is untrustworthy, they'll find your voice instead. When they want to learn about how to care for people at the end of life, how to deal with grief and loss, they'll find your voice instead of somebody who may not know or may have wrong information about things like hospice and palliative medicine. There's a lot of misinformation online. Another option is, if you're interested in writing, you can actually join our blog. We actually bring in people from across the U.S. to write posts for us. We're always looking for chaplains. But physicians, social workers, we've had medical students write for us.
Mary, you want to be a host?
Oh my God.
Think about it. And it's really easy to do. It's like 4 to 5 paragraphs every post. And it could be about an article, it could be about anything that you're passionate about. And it does give you that more, a really easy way to get a national voice. And I couldn't really end this talk without talking about concerns. So again, going to the fact that you are part of an academic institution. Even if you don't think about it, your voice carries extra weight because of that. And that means it carries extra responsibilities. Is that we should online be professional. We shouldn't be talking specifically about patients. If you do bring up a case, we, like every journal article that uses a case, you either get permission beforehand, but most probably you change as many facts as possible about the case so it's de-identified. And even in those cases, you want to be a little bit careful. And you, again, you always want to maintain that professional presence. So what are your concerns?
Time and money.
Money is the easy part because it's free on the most part, so it doesn't really take anything. Time, and just I just want you to think about it because it does take time. 140 characters we were just talking about. It seems really small, but to actually construct a tweet, like a meaningful one, it does take a little bit of time just to think about what you're going to write. But also think about the amount of time, especially for those people who are writing journal articles or publishing in traditional media. Time, that takes me a year at times, or 6 months, again, from concept to publication. That is a tremendous amount of time. And this is just another way to get information out there in a much quicker time frame, and to, dare to say it, to a much larger audience. And it also can help you, if you're doing research, promote what you're doing, to get people talking about it. Because the worst thing that can happen is that you work on something for several years to get a study out, to get it published, and then 5 people read it in a journal. That is not what we want. That's not why we're publishing. That's not why we're in academic medicine. That could be about education, it could be about hospice palliative medicine, quality of life, it could be about anything. But it needs to get out there. Questions?
Two of our fellows actually did a study. They submitted an abstract to AHP. I don't know if you guys want to talk about it, because I think Eric will be interested in that.
It's actually about social media, YouTube, and the study consisted of we had like search criteria on hospice and palliative medicine, and what type of videos came up, and if they were evidence-based, if we thought they were useful or not useful. It was interesting.
So what did you actually find?
We actually found that most of the videos posted by healthcare professionals were very useful, but the ones posted by, I would say, lay people weren't as useful.
Which came up first?
Well, it was interesting because if you had 2 search criteria, one was relevance, and
Yeah.
the other one was view count. When you search view count, it was interesting because the music videos would come up, so we don't recommend doing that. But the other search criteria came up pretty useful.
What music videos have palliative medicine?
No, like a search criteria would be grief, and it would be a love song about grief.
Okay.
So view count wasn't great, but the other.
Yeah, one of the things that I saw in it was, so I was working with Sam, is the more lay terms that you started using, the worse the results were. So pain, if you know, searching for pain on view count was probably the absolute worst. I mean, I don't think there was one relevant video in the top whatever.
Yeah.
But pain on relevancy, I don't think there may have been a few relevant videos, but again, was mostly music videos by T-Pain and stuff like that. but as you move to palliative care searching, yes, the results were more relevant, but I don't know that as many lay people would be searching for palliative care.
Yeah.
That's the problem, to make that term meaningful or useful, as useful as we think it is.
Yeah. But also thinking about if people aren't using the term palliative care, what terms are they using, and how do we get our content to those terms? It's the power of what we call search engine optimization. Is nobody is going to be Googling palliative care except for healthcare professionals, because most people have no idea what it is. It is important once they Google it that we tell them what it is, but what are they Googling? They're looking up things on end-of-life care. How are they looking that information up, and how can we get our content to those places? So instead of T-Pain, our video is there. And we actually say that with our titles of our posts. Our posts that include more lay terms actually have a lot more hits from people through Google than very complicated medical terms in the title where nobody really Googles those terms. That's great.
Thank you very much.
Thank you.
That was great. Any other questions or comments?